So let's see the patient slide, please. So this is a patient, a 27-year-old, who has a significant history of progressive dysphagia. She's got achalasia type 2. She's had a helemyotomy, a dual fundoplication. Her symptoms came back, significant Eckhart score, big loss of weight. Then had an endoflip. The endoflip, that's the impedance telemetry, showed that she had a distensibility of 3.8 with a diameter of 10.9. The diagnostic threshold is probably either a distensibility of 2 to 3, not fulfilled, or a diameter of less than 13, which she does fulfill. So she probably has an incompletely treated lower esophageal sphincter. Her swallow SMD is actually an English barium swallow, showed no passage past the lower esophageal sphincter, and therefore she has already had a pneumatic dilatation to 30 with a good result, but the symptoms are back. So the plan today would be for doing a bigger pneumatic dilatation. So the first question is, Michele, why are we doing pneumatic dilatation and not poem?
Because she had myotomy, and so she's post-surgical, I would say.
So no problem for doing poem with that.
Yeah, but we have seen that basically, yeah, after the endoflip and the SMD, I think it can be useful to do this, since maybe it's related to the surgery and not the
fundoplication, you mean? Yeah. So the issue is the fundoplication. Of course, there are two issues going on here. It could be the LES, incompletely treated lower esophageal sphincter. Could be the wrap that's too tight, and therefore with POEM you will only treat the LES. You will not treat the wrap. With balloon dilatation, you will treat both.
Exactly.
So that's the reason for using balloon dilatation, not POEM, because I do, as you well know, prefer to use POEM in a young patient if I can. So let's assess the lower esophageal sphincter.
So here we are.
We'll just come back because there's some really nice features here. Stop, pause, right. What are the features of stasis present on this image?
You can see chronic esophageal inflammation, this aspect of the esophagus that is like wet papier-mâché.
Yeah, like your skin's been in the bath for too long, like you're wrinkled if you've been in the swimming pool for too long.
Exactly.
Esophagus is the same.
We have also some food here that, of course, is food stasis that is causing this chronic esophageal inflammation. And we have also dilation just before the LES.
Yeah, we have food stasis, we have water fluid stasis, we have papier-mâché / wrinkled furrowed esophagus. We also, by the look of it, have a bit of a tight area around the LES. So should we have a look then?
Yeah.
Let's define the anatomy, pretending we're doing Barrett. So let's go and look for the, it does seem to be relative. There's a bit of a diverticulum there, even, isn't there? Just above. So at 12 o'clock, you see a small forming diverticulum, and you see quite a developed something there. So just go through the LES there. We don't see, which is quite a good sign. Actually, just come back. Quite a good sign as well. Come back. And maybe we come back. So when you push in, you don't see the columnar epithelium.
No.
You notice that? So that's something very abnormal. Normally, you see the columnar epithelium straight away when you put a gastroscope down. Here, you don't see it. So it's clearly too tight.
Yeah.
And actually, the behavior of this looks like the wrap is too tight rather than anything else, just looking at it. Let's do retroflexion. So here you can see, just push in a bit, like really, no. Really just push. That's cool. Push, turn, push. Just show an overview. Left a bit. So we, other way. Yeah, good, like that. So you see the wrap clearly here. And you see quite a developed flap valve at the bottom. Is that a flap valve? Is that a wrap? I don't know. Are the surgeons there? If they're not, then
it's a door.
Huh?
It's probably just a reconstruction of the angle of his. It's not a real fundoplication, I think.
Okay, so the surgeon hasn't done a very good job, is what you're saying, Elke.
Well, we were discussing the endoflip measurements, and I think the surgeon has done a thorough Heller because your distensibility was 4, which is normally our goal. but
Agreed.
the diameter was quite small, so I do believe that there's a problem with the fundoplication.
Perfect. So for the first time in a long time, endoscopists and surgeons, this is a joke, of course, are on the same page.
Yeah. Now,
Okay.
now
Remove the food.
Yeah. Now I would also desufflate the stomach.
Yeah, and we need to put a wire, I think. So this wire is quite a Savary wire.
Yeah.
Savary wire. It's very, very traumatic. You must bear that in mind when we're placing it. Okay? As in, don't just do what you do with another wire, which is suck that out. Just take the scope out. Could you? Yeah, all right, do that. Fine.
Yeah.
These pieces are probably okay.
It's actually air and food.
The reason why we're using a Savary wire now is because it's reusable, right?
Yeah, I think that's one of the reasons. Also, it's relatively stiff, right? The Savary wire, and it's stiff for the balloon. Okay, so we're going to put the wire in, and you got the soft end there, or
Soft end.
yeah, okay. So Michele's got the soft end. We're joined in the room by Jolien. Nurses have changed, so it was Tamaz, is now Jolien, and Jolien is one of the very experienced nurses in the department. Thank you for your help, Jolien, on the course. Okay, so deploy this in the antrum, I think is a good idea, under vision. Yeah, this is fine, it's enough. Okay, and then you need to exchange it with the endoscope like we showed in the previous case. So push it out now, push it out. Okay, someone needs to pull the scope back. I suggest you use the wire and Jolien pulls back the scope.
Okay.
So you push in the wire and she pulls the scope out.
Put it in, and I put it back.
Push in, push in, push in. Okay, we're going to come all the way out out of the mouth.
Now we can.
Soft part is deployed. Go, Michele, more.
Yeah. Slower, please. No, I was saying slower to
More in. Yeah. To grab the wire at the mouth when it comes out. Michele, grab it. Michele, grab it. Don't let it go. And then take the scope off once we have marked it. Yeah. So Jolene's all over this. She's already marked it with almost a forceps type thing. And Michele's now holding that. So we know the wire has not moved probably this time. And now let's check it with X-ray 1 tap. Perfect. So much better than the previous time. Endoscope not necessary. So we remove the endoscope. And now, so fluoro predominant image would be great, Carrie, please. Because this is entirely dependent on the fluoroscopic image.